So I'm going to talk to you today about the management of rheumatoid arthritis, which is my favorite topic to talk about. If in the last few years you haven't discarded a major opinion or acquired a new one, check your pulse. You may be dead. Well, this quote wasn't written about rheumatoid arthritis specifically, but it could have been. And the reason it could have been is because forget everything you learned about rheumatoid arthritis 20 years ago, 10 years ago, 5 years ago, because almost none of it applies other than diagnosis of the disease, and some of that has changed. As far as how we think about our goals for treatment of these patients, our expectations for how they're going to do, and certainly how we treat them have all changed drastically. So rheumatoid arthritis is a systemic autoimmune disease of unknown cause with its primary manifestation in the synovial tissues. In that definition are really a number of very important points. Rheumatoid arthritis is a systemic disease, and everybody with rheumatoid arthritis has systemic features. So it's not just about the joint problems. The generalized inflammation in the body is the prime reason that these people die prematurely of atherosclerotic heart disease and strokes, which is really an important manifestation of this disease. Most of these patients are anemic. All of them have fatigue when their disease is active. Other patients have more obvious systemic features like lung involvement, heart involvement, skin involvement, etc. We don't know what causes rheumatoid arthritis, but increasingly we're getting some clues, and I'll talk a little bit about that. Despite the fact that it's a systemic disease, its primary manifestation is in the synovial tissue. And you can think of this disease as a cancer of the synovial tissue. Synovial tissues grow too much, and when they do, they cause problems. They produce too much synovial fluid, which leads to the effusions that are pathological. They stretch tendons and ligaments, particularly in the small joints of your hands and feet. And that synovial tissue eats away at the bone and undermines cartilage and leads to the erosions that lead to deformity. What's a joint like this doing in a nice girl like you? Well, I use this slide a lot when I talk about rheumatoid arthritis because it makes a number of important points. Rheumatoid arthritis is 3 times more common in women than it is in men. It occurs in women in younger ages than it does in men, particularly in women of childbearing age. So it's not uncommon to be faced with a young lady who has rheumatoid arthritis. The doctor's holding up an x-ray there, showing off some of the damage and destruction that this disease can cause. So we're all faced with this in our office on a regular basis, particularly if you're a rheumatologist and even if you're a family physician. So how do we recognize rheumatoid arthritis? Well, rheumatologists have an annoying habit of having criteria for their diseases, which makes it hard to remember. And it's not just because they want to make it tough on you, it's because there's never one single thing that can make a definitive diagnosis of rheumatoid arthritis for you. So there's 7 criteria, and the first 5 criteria here are all criteria that require a good history or a good physical examination. So the diagnosis of rheumatoid arthritis is what we would call a clinical diagnosis, because that's where most of these are. Only one rheumatoid factor requires a blood test, and one an x-ray change. Very importantly, the first 4 criteria there, the ones with the asterisks by them, need to be present for 6 weeks before you can make a definitive diagnosis of rheumatoid arthritis. One of the things I'm going to harp on today is, if you don't remember anything else, is that early treatment is critical for the success of these patients. Early treatment with disease-modifying drugs. That said, we can't make a definitive diagnosis of rheumatoid arthritis till about 6 weeks. Because if a patient comes into you and they fulfill all of these, they could fulfill most of these criteria. Most of them wouldn't have nodules or radiographic changes, but they could have 5 criteria, which is more than enough to be classified as having rheumatoid arthritis. And they've only had symptoms for 3 or 4 weeks. It's a better than equal chance that that patient's going to have a self-limited arthropathy, usually secondary to virus, and it's going to go away and they're going to be just fine. So including rheumatoid factor positivity. So we have to wait 6 weeks or a little bit longer before we're real comfortable with that diagnosis, according to these criteria. I'll come back to that in just a minute because there's a new test out there that's going to help us change that a little bit. Rheumatoid arthritis is a serious disease. It literally takes lives. And I mean that in a literal way because this is the amount of life that's lost because you have a diagnosis of rheumatoid arthritis. And nowadays that's someplace between 3 and 12 years, depending upon the study. So you don't live as long as if you have rheumatoid arthritis. And as I mentioned earlier, that's primarily because of the inflammation in blood vessels. But it also causes a disability that's additive as the disease goes on, certainly discomfort. We get certain iatrogenic things that come along. And there's a tremendous economic burden to this disease, both in terms of direct and indirect medical costs. This is another way of looking at rheumatoid arthritis. This is 10-year survivals. And up here in the upper left-hand corner, we have rheumatoid arthritis based upon activities of daily living. We have based upon education levels. We have Hodgkin's disease down here based upon the stage of disease. And over here we have coronary artery disease based upon the number of arteries that are involved. And depending upon the curve you pick, the prognosis amongst those diseases is quite similar. So I'm not here to tell you that rheumatoid arthritis is Hodgkin's disease or coronary artery disease, but I am here to convince you that this is a disease we should take seriously, just like we take these other diseases. These patients, in general, are going to need to be taken care of in conjunction with their primary care physician, as well as a rheumatologist. And if we take care of them well, we will beat the odds on these curves. So let's get a little bit more clinical here. This is rheumatoid arthritis as it can present even early on with swelling of the PIP joints. Rheumatoid arthritis generally starts out in the small joints, PIPs, MCPs, and MTPs. Later, rheumatoid arthritis metastasizes to larger joints. And that's the way it goes for most folks. Occasionally, patients will present early on with major joint involvement, but usually it's small joints of the hands and feet, and if we treat it early enough, we can keep it from involving those other joints. If we're not doing a very good job of treatment, by 5 years, these patients will have ulnar deviation, they'll have subluxation at their MCPs, and they'll start to have the deformities and the disability that goes along with them, and that's obviously what we're trying to prevent. No, Mr. Tidwell, it's not a very good prognostic sign. Well, having rheumatoid arthritis is not a very good deal. But what we're going to spend the rest of the time today on is learning how to get this vulture to fly away. Well, one of the things I mentioned that's now out there and it's ready for prime time is a new test that's called the anti-CCP antibody test. And if you haven't heard of that, then you should, because this test is revolutionizing how we think about rheumatoid arthritis patients early on in their course. So this is an antibody that recognizes citrinated peptides. And I won't get into how you citrinate peptides. There's enzymes in your body that do that. There's environmental exposures that help you do that, one of which is smoking, etc. But when you citrinate peptides, and you have the genetic predisposition to have rheumatoid arthritis, you help turn on the immune response. This is complicated numbers, but what the bottom line here is that in the Netherlands, they followed a group of patients, over 300, who had early symptoms of arthritis, but they didn't have enough going on that they could make a definitive diagnosis of rheumatoid arthritis in them. And so they said, well, let's follow those patients for 3 years and see what happens. And they broke them up into two categories. The people that had positive CCP antibodies in this group, the light blue, and the people that were negative CCP antibodies. And if you were in that group of patients who had early arthritis that wasn't enough to make a diagnosis of rheumatoid arthritis, if your CCP antibodies were positive, almost all of those patients at the end of 3 years ended up having true rheumatoid arthritis. So this is a test we now use early on in the disease to help us to be more comfortable with that diagnosis. And if you see a patient with early arthritis symptoms and their CCP is positive, there's an extraordinarily high likelihood, well over 90% probably, that that patient indeed does have rheumatoid arthritis. Not only is this a helpful diagnostic test, but it's telling us a lot about the pathophysiology of rheumatoid arthritis. which is more than I'm going to talk about today. So let's get down to management principles. The most critical thing is to make this diagnosis early and to get therapy started early. And our goal for all patients with rheumatoid arthritis would be to have them on what we call disease-modifying therapy, and we're going to go through that in just a minute, by 3 months after symptom onset. It's very important that we have a lofty goal for these patients. Just control of their symptoms and having them not complain too much isn't good enough. We should have a goal of putting all of our patients in remission. And nowadays, that's achievable in about half of our patients, and we can get close to remission in well over 80% of our patients. That's numbers that I wouldn't have dared talk about a few years ago. In addition to escalating DMARD therapy to do that, supportive measures, education, PT, OT are important. And finally, we'll say a few words at the end about surgical management. The asterisks up here are consultation with the rheumatologist. For lots of reasons, because things are changing so fast, because this is a serious disease, because it has serious implications in terms of morbidity and mortality, a rheumatologist should be involved with this disease. But there's many, many issues that a primary care physician needs to be dealing with. Well, this is a slide that emphasizes the importance of early therapy. I could show you any one of about 10 studies to make this point, but I've chosen this one because this is a group of patients, again from the Netherlands, and the group of patients here in green got early therapy. And this is an index of badness in terms of how their x-rays were progressing. And this was early therapy as judged by about 4 months after onset. So that's pretty good. This is very early therapy. Therapy within 15 days of the time the diagnosis was made. And you can see that these people are no longer radiographically progressing. This is quite a minimal progression. So it made a big difference whether they got therapy early versus very early. And this is certainly what one of our goals is. So how do we accomplish that? Well, we use several different categories of drugs when we treat rheumatoid arthritis. We can break them up into the non-steroidal anti-inflammatory drugs, steroids, and disease-modifying drugs, both conventional and biological. So this is what I call musical non-steroidals. This is what we hope that you and I don't do with our patients, okay? And all too often we do, though. So what happens is a patient comes in with some symptoms of rheumatoid arthritis or arthritis of some sort. We say, okay, take this latest COX-2 drug, if there's still one left at least. Take some naproxen, take some ibuprofen, whatever, and try it for 2 or 3 weeks. Doesn't work, try another one. If that doesn't work, try another one, etc. And we end up playing musical nonsteroidals with our patients. Nonsteroidals, I'm not going to say much about them today. Dr. Claassen is going to talk a little bit more about them, are never the answer for rheumatoid arthritis. So let me say it again. They're never the answer for rheumatoid arthritis. They're very useful for a high percentage of our patients, but they're never the answer by themselves, okay? So every patient with rheumatoid arthritis, with very rare exception, needs to be on a disease-modifying drug. So let me introduce the next category of drugs. On September 21st, a 29-year-old lady who was unable to ambulate because of severe seropositive rheumatoid arthritis was given a new therapy. Dramatic, almost miraculous improvement occurred, and on September 27th, she was out walking around town shopping. Well, if this was last year, maybe that new therapy was rituximab or abatacept or Rincia. But in fact, it was 1948, and she was in Rochester, Minnesota, and she was given steroids. So the first patients in the whole world to ever be treated with steroids were patients with rheumatoid arthritis. And the rheumatoid arthritis was chosen as a disease to treat first with these precious compounds because it was felt that rheumatoid arthritis was a steroid deficiency state. And there's actually still some evidence that may be true to a partial degree. These are the first 14 patients that got steroids at the Mayo Clinic for rheumatoid arthritis. And all of them improved their sedimentation rate by at least 50% in less than a month. And most of them improved their sedimentation rate by 70%. 80% of the patients improved their sed rate by 70% by a month of therapy. Steroids are dramatically successful therapies for the treatment of rheumatoid arthritis, both in terms of making patients feel better and in terms of preventing radiographic progression. Okay? That said, they have all the side effects and toxicities that you're all too familiar with. So steroids have a role to play in the treatment of rheumatoid arthritis, but we need to be really careful about how we use them. Prednisone in excess of about 10 milligrams a day is very rarely indicated for articular symptoms alone. I'll have maybe 2 or 3 patients out of 300 that I take care of with rheumatoid arthritis who will be on more than 10 milligrams a day. And most of those are because they have vasculitis or something else that goes along with their rheumatoid. Just like nonsteroidals are never the answer for the treatment of rheumatoid arthritis by themselves, steroids are never the answer. Your goal is always to use steroids because they work very quickly to get you to effective disease-modifying therapy so that you can get rid of the steroids. So you don't want to have patients on steroids without disease-modifying drugs. So you want to use them as a bridge to effective DMARD therapy. We want to minimize the duration of therapy, want to use it at the lowest levels, and we want to consider prophylaxis for osteoporosis. We now know that bisphosphonates are very effective in preventing steroid-induced osteoporosis. So if you're thinking about having a patient that's going to need to be on steroids long-term, you need to be thinking about protecting their bones. Now that's problematic if you have women in the childbearing age, because bisphosphonate therapy and pregnancy is a major concern, and in fact it should be avoided. So that's an issue. But if you have a postmenopausal female you're going to put on steroids for long-term, bisphosphonate therapy is highly effective. Anybody on steroid therapy should be taking a gram to 1,500 milligrams of calcium and adequate vitamin D, because one of the things that steroids do is they decrease the GI absorption of calcium. So you can counteract that with calcium and vitamin D. All right, so nonsteroidals are helpful, but never the answer by themselves. Steroids are dramatically effective, but never the answer by themselves because of their toxicities that are additive over time. So the answer is disease-modifying drugs. And we have a whole list of conventional disease-modifying drugs, and now we have an increasing list of biologics. 2 have been added here in the last few months, rituximab and abatacept, or Rincia. And so we're going to spend a little time talking about these. So this is our RA wheel of empiric therapy. And the patient gets referred to my clinic for rheumatoid arthritis, and I'm trying to decide what to treat them with. And so I get paged out of the room, and I go in my little room where I have my wheel, and I spin the wheel, and it's all automated. It spits out a prescription that says sulfasalazine or methotrexate. I go back in the room. I act like I know what I'm doing and explain to the patient what they ought to be taking. And I'm kind of poking fun at ourselves here a little bit, because we never know what the right drug is for any individual patient until we try them. And there's a lot of art to this in terms of finding the right drug and finding the right drug combinations for different patients. There's a tremendous amount of research. The hottest area of research in the therapy of rheumatoid arthritis evolves around that question, and that is figuring out parameters that help us to predict up front who's going to respond to what therapy. And we're doing a lot of that research here at the University of Nebraska. So until we get the answers to that, some of our initial choices will be empiric. Well, this is some data from the 90s that shows us a whole bunch of our different disease-modifying drugs and how long people actually stayed on them. They would come off of the disease-modifying drugs because of toxicity or because they weren't working anymore. And the one that stands out as the most durable there is methotrexate. And so that's become by far and away the most popular drug for the early treatment of rheumatoid arthritis. And that's been true in the United States now for well over a decade, and in Europe more recently, but it's true there as well. All of these disease-modifying drugs take a while to work. The only things that work, within a few days, or certainly within a week or so, for improvement in symptoms are steroids and some of the TNF inhibitors. Everything else takes longer than that. And your patients have to know that, because if they don't, they'll be calling you up, you know, the next day or a week later and expecting to have gotten a lot better, or they'll stop taking the drug because it wasn't working after a few weeks. They didn't feel any different. Methotrexate works fairly quickly if we get people on the right dose, 1 to 2 months. It's effective in at least 80% of folks, but not necessarily completely effective in that many. It's usually given as an oral medication, but it's more effective, actually, if you give it parenterally. And sub-Q works just fine. It's absorbed just as well as IM. So if the oral isn't working, you can switch to sub-Q. Toxicities include mouth sores, which are very common if you don't use folic acid with it. And nowadays, all of our patients, essentially all of our patients on methotrexate are on 1 milligram of folic acid a day, and that prevents a lot of the toxicities, mouth sores, nausea and vomiting, liver enzyme elevations, even cytopenias are all prevented largely by the treatment with folic acid. We monitor for those toxicities. Probably the most important toxicity that you need to know about with methotrexate as a primary care doc is the pneumonitis. It's uncommon, but when it happens, it can be severe. So any patient who is on methotrexate who comes in with increasing shortness of breath or with a little infiltrate on chest x-ray, the methotrexate should be stopped and not started again until you're convinced that you know what you're dealing with there and it wasn't the methotrexate that did that. If somebody has honest-to-goodness methotrexate pneumonitis and you restart the methotrexate, the published mortality rate for that for your patient is 50%. So that's pretty scary. Very rare complication, but when it happens, it can be bad. And so if you have a patient with increasing shortness of breath on methotrexate and infiltrates in their chest x-ray, stop it and get some help. These patients need monitoring for the rest of their life if they're continuing to take methotrexate. People will get on methotrexate, they've been on for 2 or 3 years, and people say, well, they've been doing well, we don't need to monitor them anymore. Wrong. These people can and do get into trouble at any time. If we monitor them correctly, they do fine. The best way to get a patient on methotrexate in trouble is to have something go wrong with their kidneys. So methotrexate is cleared primarily by the kidneys. Methotrexate rarely, if ever, causes any renal toxicity. But if your patient has a decrease in their renal function for any other reason, maybe you put them on a non-steroidal when they weren't on that, maybe they have a little renal disease, maybe they have a little congestive failure, then their methotrexate all of a sudden becomes more toxic. So we monitor creatinines in these patients, we monitor CBCs and albumin every 4 to 8 weeks. And if you do that, they do quite well. So there's some caveats with methotrexate, and this is probably one of the most important areas I'm going to talk about in terms of therapy, because most patients with rheumatoid arthritis nowadays are on methotrexate. It's a once-a-week drug. When you give it more often than that, the liver gets really angry and dies sometimes. And that's what happened in the 60s when people used to treat psoriasis with daily methotrexate. We now use much higher doses than that, but if the liver sees it once a week and can recover, then it's going to do just fine in almost all cases. The liver toxicity of methotrexate nowadays is very, very minimal. Rheumatologists sit around and talk about if they've ever seen a case of liver toxicity that's led to anything bad because we give it once a week. So that's really important. Every once in a while, you'll see a patient that will not understand that and will be taking their methotrexate daily, and that's not good. Most effective if given sub-Q. Toxicities are decreased if you use folic acid along with it. Change in renal function will signal problems. You want to decrease your dose if your liver function tests are elevated on not just a one-time basis, but on a consistent basis. And beware of the pneumonitis, as I've already mentioned. So those are some important caveats with methotrexate. Hydroxychloroquine or Plaquenil. A drug that's used quite a bit for the treatment of rheumatoid arthritis and used extensively for the treatment of lupus. That's a very good drug. It's the safest of all of our disease-modifying drugs, and it's one of the easiest to monitor because it doesn't require any laboratory follow-up. What it does require is an eye checkup yearly. Now, if you read the PDR, it'll say more often than that, but there's extensive recommendations from the rheumatology community and from the ophthalmologists that tell you that yearly follow-up is more than adequate for this drug. And the secret here is not exceeding the dose of 200 to 400 milligrams a day. Its effectiveness isn't quite on the level of methotrexate. It takes a little bit longer to work. Toxicities are very rare. Retinal toxicity, again, is something that you'd almost write a report up about. If they hit their yearly eye checkup, nobody is going to have any irreversible eye damage from Plaquenil. If they don't get their yearly eye checkup, maybe 1 in 10,000 might. You can get myopathies, neuropathies from long-term Plaquenil use, but it's a very, very, very well-tolerated drug. In the treatment of rheumatoid arthritis, we almost always see Plaquenil used in the context of other medications, so methotrexate and Plaquenil combinations, etc. Sulfasalazine, or azolfidine. And this is one of the few, if not the only drug, specifically designed to treat rheumatoid arthritis. So in the 40s, in Sweden, they said, well, rheumatoid arthritis is caused by an infection, so let's take an antibiotic, and it's an inflammatory disease, so let's take an aspirin cousin, and let's put them together, and then we'll have this great drug to treat rheumatoid arthritis. Everything else that we used to treat rheumatoid arthritis was originally came about for other reasons, including all the new drugs that we use, the biologics. Well, it works. Maybe not exactly for the reasons that they thought it was going to work initially when they put it together. It also doesn't work right away, 2 to 4 months. Effectiveness about 65% of the time. 1 to 3 grams a day is the dosage. The toxicities are similar to what we talked about with methotrexate, but much less, particularly with regard to the liver. You need to do CBCs monthly for the first 6 months or thereabouts, and then after that, once or twice a year. Because if you're going to get a neutropenia from this drug, you do it very quickly, and if you don't get it very quickly, then you're not going to get it. And so once you have patients on chronic therapy with sulfasalazine, it's very easy to monitor. One caveat here is that the real cheap sulfasalazine, that's generic, that's not enteric-coated, is not very well tolerated. So it's the coated, enteric-coated tablets that are much better tolerated. So if your patient's having GI toxicities, as they often do, then the enteric-coated is necessary. In 1998, the first new DMARD in a long time was approved for the treatment of rheumatoid arthritis. That's leflutamide, or Areva. And it also takes 2 to 3 months to work. It has a very long half-life. And so initially, when it was released, a loading dose was recommended. You can still do that. You can still see that in the package insert, but almost no rheumatologists do that anymore. And the reason is because it increases toxicity. The main toxicity of this drug is diarrhea. And that makes a little bit of sense because it circulates in the intrahepatic circulation. So once a day dosage is more than adequate for this drug. And if they're getting diarrhea, we will often have patients on this therapy 2, 3, 4 times a week instead of daily. And it's quite effective. But one of the caveats here, is that it has a very long half-life. And like methotrexate, it's a big-time teratogen. So methotrexate and leflutamide are the 2 drugs that you really got to worry about in terms of pregnancy, in terms of patients with rheumatoid arthritis. Some of the rest of our drugs you have some concerns about. Methotrexate and leflutamide, there's no doubt that they're really bad. And the thing about leflutamide is it's around for a very long time, years, if you don't do something about it. So if you have a situation where you have somebody who's been on leflutamide, they want to get pregnant, or if they're on leflutamide and they have problems with toxicities, remember that you can get rid of it with cholestyramine. Okay? And there's a protocol in the package insert, 11 days, I don't know why 11, but 11 days of cholestyramine, and you'll get rid of all the leflutamide that you have. And the patient can then go ahead and get pregnant, or you'll get rid of the toxicities that are associated with leflutamide. Well, this is Tomoka. And Tomoka was a famous gorilla in the National Zoological Park in the late 60s. People would come from all around the world to see Tomoka because he did what gorillas do. He scratched his armpits a lot, beat on his chest, threw things, very vocal, very playful. Everybody loved Tomoka. Well, Tomoka came down with arthritis, and he wasn't very vocal anymore. He just kind of laid there. So the call went out for a rheumatologist, a brave, courageous rheumatologist, to go in and take care of Tomoka. And the call was answered by a rheumatologist who was rather famous at the time, soon to become infamous, by the name of Thomas McPherson Brown. And Dr. Brown treated Tomoka with tetracycline. And Tomoka got all better and went back to his old antics, jumping up and down and scratching his armpits again. Everybody was happy. Well, Dr. Brown then decided that tetracyclines were the cure for rheumatoid arthritis and most anything else that ails you, and told all the rest of us in the medical profession, Mike and I, of course, were too young at the time, that this was how we ought to be treating all of our patients. And that's how the treatment of arthritis with tetracycline started. Well, it turns out that Tomoka actually had chlamydia-induced arthritis, and that was proven. Now, I was giving this talk in Australia one time and to a lay audience, and a little lady in the front row raised her hand and she said, "Doctor, how did Tomoka get chlamydia-induced arthritis?" And I knew that she knew exactly what she was asking me by the way she asked it. So I don't have any idea how he actually got chlamydia-induced arthritis. But he did, and he got all better with tetracyclines. Well, that started the whole tetracycline story. And it actually, because of Dr. Brown's approach to this whole thing, it put research back in that area for decades. But in the 90s, there were a series of studies, some of which were done here at the University of Nebraska, that have confirmed the usefulness of tetracyclines, particularly minocycline, in the treatment of rheumatoid arthritis. It is now well established that minocycline, in a dose of 100 milligrams BID, or sometimes quite a bit lower than that, is a very effective therapy for seropositive rheumatoid arthritis. It's very well tolerated. It does not require laboratory monitoring. And toxicities include GI distress and dizziness. Those are usually limited to the first or second dose, although some people have ongoing problems with those and you won't be able to use it. Long-term, patients may get some hyperpigmentation. And it's very well tolerated. Here is a study that we did that shows the effectiveness of minocycline. This is a measure of 50% improvement, composite improvement, which is the primary outcome of the study. And we compared minocycline, which achieved that in 60% of the patients, with Plaquenil, which achieved that in 33% of the patients. And it did so at a lower steroid dose as well. So this is a therapy that is used, and it's fairly inexpensive. And it can be used in addition to methotrexate, as we have shown in a number of studies. Tetracyclines are not working by treating the bacterial infection that causes rheumatoid arthritis, like Dr. Brown would have had you believe. The bacterial infection, if there is one, that precipitates rheumatoid arthritis is long gone by the time you ever see a patient. The rheumatoid arthritis is triggered at least 3 to 5 years before you're going to see those patients in your clinic. But it may be treating infections in a nonspecific way that are responsible for upregulating IL-1 and TNF-alpha in your system. People who get infections, sinusitis, bronchitis, flu, etc., flare their rheumatoid arthritis. That's been known for years. And if we treat those in a nonspecific way, maybe we'll do better. Minocycline and other tetracyclines have profound immunological effects. Minocycline can induce lupus. You should all be aware of that. So this is the 20-year-old lady that comes to see you with her lupus. One of the first questions you want to know is she taking minocycline for acne. In fact, it induces DNA antibodies, which usually are fairly specific for lupus, but in this case, it could be the minocycline. Well, it doesn't do that in rheumatoid patients because in the sense of the Th1 and Th2 T cell production, rheumatoid and lupus are on different ends of the spectrum. And so it changes that milieu and improves patients with rheumatoid arthritis. And finally, tetracyclines decrease metalloproteinase production and therefore protect your cartilage. So a useful drug, a drug to remember as our patients come in with these high copays that we're all seeing nowadays, 20%, 30% copays, and are having a difficult time paying for their medications. This is what you can get if you leave people on high doses for a long period of time. You can get this hyperpigmentation. If patients are doing really well, as some of them are, they actually don't mind this too much. One of the real changes, the sea changes in the treatment of rheumatoid arthritis over the last decade has been the use of combination therapy. In the mid-90s, we didn't use combinations of therapies. There was an article published in the New England Journal in the mid-90s from the University of Nebraska showing the effectiveness of what we call triple combination therapy, which is methotrexate, sulfasalazine, hydroxychloroquine, comparing to methotrexate alone, was dramatically different. And that helped usher in the use of combinations. Nowadays, at least half of the patients taken care of by rheumatologists with rheumatoid arthritis are on combination therapies. And in most series, it's much higher than that. So we use all kinds of different combinations of these disease-modifying drugs. But you'll notice that in all the ones I've listed here, methotrexate is a constant. So methotrexate's not in every combination that's used, but it's in most of the ones that have been shown to be the best combination. So it's kind of an anchor drug. This was a study that we published in the mid-90s showing combination of all three drugs versus methotrexate alone, measuring 50% improvement at 2 years, and it was achieved by about 80% of these patients and only a third of those patients. So combinations of disease-modifying drugs are very common. I want to change gears now and talk a little bit about the biologics. The biologics have been another huge change and an improvement for the most part in terms of our therapy for patients with rheumatoid arthritis, but they have the other side of the coin too in terms of toxicities, which as primary care physicians you need to be aware of. Well, this is just a schematic, a little cartoon showing how some of these things work. So this is a TNF molecule, okay, and this is a TNF molecule, and a couple of ways to keep it from doing its badness in terms of causing inflammation is to have a soluble receptor, and we all have these in our bodies. If you don't, then you have hereditary inflammatory syndromes like familiar Mediterranean fever and TRAPS syndrome and stuff. Otherwise, we all have these circulating that downregulate our TNF. Well, we can give that now in the form of Imbro or etanercept. We can give monoclonal antibodies to TNF, okay, that bind TNF before it can activate its receptor. Those are Humira, adalimumab, or Remicade, infliximab. So those are very direct ways we can inhibit TNF from working. Down here, we're demonstrating how anakinra, anti-IL-1, works. IL-1 therapy has been disappointing in the treatment of rheumatoid arthritis because anakinra is not around very long. Anakinra, though, has a couple of niche markets. It's extremely successful in treating Still's disease, in treating some other hereditary syndromes that cause inflammation, like rare things like Muckles-Wells syndrome, if any of you ever heard of that. Dramatically effective in some of those. So another strategy is blocking IL-1. And now we have therapies that one of the latest approved was rituximab. Rituximab has been around for a long time for the treatment of B-cell lymphomas. It basically gets rid of about 80% of your B cells for at least a year. And for the most part, that seems to be an okay thing. And rheumatoid arthritis gets quite a bit better. We now have a new therapy called abatacept or Orencia that's just been approved for the treatment of rheumatoid arthritis, which blocks the second signal to T cells. And so we have therapies that are directed at cytokines for rheumatoid arthritis. We have therapies that are directed at T cells, and now therapies that are directed at B cells. And all of those are effective strategies. None of those biological therapies should be used together. All attempts at doing that so far have resulted in significant infections, complications. So when we inhibit the immune system too much, we should expect infections, and we should be concerned that we're decreasing surveillance for cancers. And those are the two main concerns with biological agents today. So I'm going to just run through real quickly here the most common ones. Etanercept or Imbro. We've all heard this. It's been around for 10 years now. Soluble receptor, well tolerated. This says 25 milligrams twice a week. It can also be given 50 milligrams once a week nowadays. The big thing we worry about is infections. So any kind of patient on a TNF inhibitor, you should be worried about infections, and you should be worried about strange infections like TB. And when TB happens in these patients, it often happens in extrapulmonary ways. But you should also be more worried about normal infections. So the cellulitis, the septic joint, that kind of thing. Anybody who has an infection should not be started on one of these, and anybody who gets an infection should have it stopped promptly. And anybody who gets an infection on one of these things, you should be worried, extra worried about them, get them in the hospital, get them worked up, etc. So close observation in terms of infections, CBCs, etc. Infliximab is given by IV infusion, and frequency of 4 to 8 weeks. And it's very similar to all my comments about Enbrel in terms of things to worry about, sepsis, tuberculosis. All these patients should be screened with PPDs before they get started on these drugs, and if they've had tuberculosis, they need to be treated. Multiple sclerosis and other demyelinating diseases have been a disturbing toxicity, very rare, but disturbing. There's also the concern that there's an increased incidence of lymphoma with these drugs, and more recently with solid tumors. All of those things are small percentage-wise, but they may become greater concerns if we have patients on these drugs for a longer period of time. So like a lot of new products, we still have a lot to learn with these drugs. And because of their cost and because of their potential toxicities, we need to be very vigilant. So the other anti-TNF agent is adalimumab or Humira. Similar comments to Enbrel because it's a sub-Q, and we can give this usually every other week. Again, sepsis, TB, multiple sclerosis. Congestive heart failure has also been a concern with these products, and that's a patient with congestive heart failure, you should be careful with TNF inhibition. Well, this is what I call the TNF thermostat, and it could apply to any other biologic or any other drug that we give for that matter. And the problem is we don't know how to measure when we're doing this too much or too little. So what we'd like to do is push this needle over here to the middle so that we get this happy face, okay? But if we push our therapy too far, we're going to get a TNF deficiency state, and patients are going to have big-time problems with infections and probably with immune surveillance for their cancers. We obviously want to get them out of this red quadrant so that their manifestations of their rheumatoid or whatever disease we're treating. Unfortunately, we can't measure that directly. People are working on that as well. If we could measure a level of this suppression-wise, we would be very much smarter in terms of doing better for our patients and decreasing toxicities. So caveats, there's central cytokines for normal immune function. If we inhibit them too well for too long, we're likely to have toxicities. Everybody should have a PPD prior to use. You stop if any infection, and you avoid in patients with cancers or demyelinating syndromes if they have those in their histories, or congestive heart failure, I might add. For Pete's sakes, let's operate. While we stand here, he's getting well all by himself. Well, this is a group of surgeons, of course, standing around talking. And increasingly, they're standing around with our patients with rheumatoid because they're doing enough better that they don't need as much surgery as they used to. But surgery has a significant role to play for our patients with rheumatoid and osteoarthritis, particularly total joint replacements, hips and knees, have made a world of difference for these patients, and you're all familiar with the benefits of those procedures. No surgeon can tell you when it's the right time to replace a hip or a knee. It's only the patient who can tell you that by how much trouble they're really having. Operations on the feet in rheumatoid patients are also very successful as they get these hammer toe, claw toe deformities. This is a patient with carpal tunnel who's lost their thenar eminence there. You can see that it's basically gone. We waited too long to operate on that patient. If we can't take care of the disease, these patients should have carpal tunnel releases. So in summary, the keys to optimize outcomes is early diagnosis, treat as early as possible, strive for remissions. We have to have high expectations for these patients if they're going to do well. And we need to consider and treat comorbid conditions. I haven't emphasized that probably enough for this audience. These patients are going to die of their coronary artery disease prematurely. They're going to die of their strokes prematurely because they have the first hit to their blood vessels. That's inflammation. Okay? And so you should have high standards in controlling blood pressure, other risk factors for getting LDLs down. And by the way, statins are anti-inflammatory. Statins are a treatment for rheumatoid arthritis in and of themselves. If you take a group of patients with rheumatoid arthritis on statins and a group that aren't, the ones that are on statins are going to have less active disease. And that's interesting. Mr. Jones must know all about his rheumatoid. He's had it for 10 years. Well, I think this is a a trap that all of us fall into with our patients. If they, we think, well, they've had it for a long time, then they should know all about it. Well, they don't. Our patients continue to need education about their disease. They need to have an opportunity to see occupational and physical therapists at least once during their course. There's lots of devices that are available for these patients that can make a world of difference in terms of everyday tasks like turning on and off faucets and turning their car keys or getting in and out of their doors at home, etc. And if they don't know about these things, then they won't get the benefits of them. Devices to help them pick things up off the floor, long shoe horns, etc., can all make a huge difference for quality of life. Build-up devices for pencils, extra big grips for golf clubs, for the toothpaste and for the toothbrush, etc., can make a big difference for our patients. Devices to help them around the house.
If the anti-CCP antibody is positive 3 years prior to the traditional criteria to make rheumatoid arthritis, is that the same category of patient that we used to describe as seronegative rheumatoid arthritis?
Well, probably not, because the patients that we talked about as seronegative rheumatoid arthritis actually had arthritis, or we wouldn't have been talking about them. Okay, so the comment, though, that CCP antibodies and in some cases rheumatoid factors are present years before you actually develop clinical disease is a very interesting one, and we know this from studies that have been done in military personnel who have had blood samples drawn serially for years. And then you can say, oh, they developed rheumatoid arthritis in 2000, but they had all this blood saved, and you can go back and look at that. Or in Europe, they have anybody who ever donates blood has an aliquot of serum saved from the time they donated blood. And then you can go back and look at that. And what we're realizing is that the patients have these antibodies present for years before they develop it. So that patient who has CCP 2 years before they develop rheumatoid arthritis would be, most of the patients that are CCP positive are also rheumatoid factor positive, but not all of them. Not all of them. And in fact, increasingly, we're recognizing that CCP is probably a much better test than rheumatoid factor. It's more correlated with disease outcomes. So again, everything we learned about rheumatoid factor, probably a decade from now or 5 years from now, will disappear from the literature. I mean, that's a bold prediction. But from all we were learning about CCP, it looks like it's going to come true. So some of those patients who we've traditionally called seronegative rheumatoid are CCP positive, and so that it does cover some of that group.
I had a patient who had a classic picture of rheumatoid, everything that you had there except negative rheumatoid factor, never became positive. Mm-hmm. Can you ever get that type of thing and call it rheumatoid arthritis?
So only about 80% of our patients with rheumatoid arthritis, with true rheumatoid arthritis, are rheumatoid factor positive. In general, the patients who are rheumatoid factor negative have a more benign course. But there's a subset of those that have the very worst course. Some of those patients, nowadays, we would recognize as CCP antibody positive. So if we look at both rheumatoid factor and CCP, that's going to take in about 90% of patients now. There's still 10% out there that we don't understand in terms of antibodies. Rheumatoid arthritis will probably turn out to be, when I give this talk 10 years from now, if I can still talk or stand up, or maybe a little later than that, we'll probably talk about different subsets of rheumatoid arthritis or maybe different diseases. So rheumatoid arthritis we should think about it more like a syndrome. One of the amazing things that's occurred in the last few years, and it dovetails with the CCP antibody story, is that if you have the worst genes for rheumatoid arthritis, which is called shared epitope, and if you have 2 copies of that, and if you're a smoker, your chance of developing rheumatoid arthritis is increased 55-fold over the general population. That's a pretty significant increase. It's now estimated that at least in shared epitope positive patients, which make up about 2/3 of the patients with rheumatoid arthritis, if people didn't smoke, the incidence of rheumatoid arthritis would go down by 1/3. But so smoking is a big thing. If you have a patient who's worried about developing rheumatoid arthritis because of family history, the best thing you can do to tell them is not to smoke. Now, that doesn't make up for the majority of rheumatoid arthritis, maybe a third at most. So there's other things going on that we don't understand, but we're understanding more and more of those.